Welcome to AETCM, the emergency medicine channel.
Yeah, please.
49-year-old man came to the ER with 3 episodes of seizures. On initial assessment, patient was stable, conscious, but he was confused. Airway was patent, there was no pooling of secretions. Breathing was respiratory rate 20 per minute and saturation was 98% in room air. Circulation wise, 120 by 80 millimeter of mercury was the BP and heart rate was 74 per minute. At this point, we had put a cannula and 2 large wide bore cannulas in both the...
And just one point, if you can just say when was the last episode and at the time of presentations, when was the last episode of
He
seizure?
presented at 5 p.m.
Okay.
The last episode was at 3:30 p.m.
So even after 1.5 hours, you say that the
He's
sensorium is not
confused.
regained normalcy.
Yes,
so that is an important point in history, no? Okay, continue.
Disability wise, his GCS was E4 V2 M5. He was moving all limbs and his pupil were 2.5 millimeter bilaterally equally reactive.
Yeah.
On exposure, his temperature was 97.8 degree Fahrenheit and his GRBS was 399 milligram per deciliter. On adjuncts to primary survey, we had done a CBC CRP point of care and a VBG. The CBC CRP counts were normal and the CRP was also normal. And on VBG, there was no acid-base abnormality. Sodium was 135, lactate was 4.4, and creat was 1.78, and the other parameters were within normal range. pH was 7.4.
7.4.
Yeah.
But still lactate was high.
Yeah, lactate was high, sir.
Okay.
Coming to the sample history, 49-year-old man.
Okay, at this point, what all things you have to do? So basically, you have a patient who has, from the history, you feel that there has been 3 episodes of seizures.
Yes.
The last episode was 1.5 hour before presentation. On arrival, GCS of 9/15, hemodynamically stable. Right?
Yes, sir.
So what all things you have to do at that point?
So at that point, we started injection Levipil, 1 gram IV stat for the patient. And
so you have secured 2 cannulas.
Yeah, secured 2 cannulas.
Did you keep the patient on oxygen? Was it indicated at that point?
No, sir.
Saturation was
98%
maintained.
saturation.
Breathing was appropriate, right?
He was stable, only confused at that point. No other complaints.
And pupils you feel was
Pupil was bilaterally reactive,
right?
Yes.
Okay. So Levipil you have given, but dosing?
So at that time, 1 gram IV stat was given.
Okay. Fine, we'll come through the dosing and all later. Okay. So you have given Levipil 1 gram. Okay. After that?
After that, sir, the sample history.
Yeah, please.
Yeah, he's a 49-year-old man, known case of diabetes, hypertension, CLD, CVA. Came to the ER with history of 3 episodes of seizure today. Since morning, each lasting for around 1 to 2 minutes. There was tonic posturing and tonic-clonic seizures were there with uprolling of eyes.
Okay.
There were 2 episodes of vomiting, one while coming to the hospital and one was after the first seizure. There was no history of loss of consciousness, frothing of saliva, bowel bladder incontinence, headache, facial deviation, upper limb, lower limb weakness, fever. His last alcohol intake was 2 months back. Patient was in post-ictal confusion state when he came here.
Okay.
So after arrival, he had 1 episode of active seizure in the hospital.
Okay. Before giving the drug or after?
After giving the drug.
Even after giving 1 gram of Levipil, you say that there was one more episode.
1 episode.
Okay.
Which lasted for around 20 seconds.
Okay.
And at that moment, we had given injection lorazepam. Then, sir, we had planned for an MRI stroke protocol for the patient. Sir, MRI stroke protocol was planned, and there was no acute infarct or hemorrhage. There were gliatic changes in the bilateral cerebellar hemispheres, which was previous.
Okay. Yeah. Okay,
So,
that's the history. Okay, we'll come through it once more. Okay, so we have a patient who is a known case of seizure disorder here, right?
Seizure disorder, last on 2 months back, he had a CVA episode.
Okay.
At that time, he had the first episode of seizure.
Okay, so along with an acute infarct, he had a seizure. That's what you're saying.
Yes, yes.
2 months back.
2 months back.
Okay, and he was started on something for that, right?
Levipil 500 milligram daily.
Okay, and he was continuing the medications properly, or is there a default kind of history?
So the last 3 days, he was not taking the medicine.
Okay, fine. So it's like there is a definitive temporal correlation, right? A patient with a previous episode of seizure, so we'll label him as a known case of seizure disorder, now with a drug default. Okay, so most likely that can be the trigger, but definitely we need to rule out other causes which might be contributing to a new onset seizure, right? So what are the etiological parameters you will consider when you have a patient coming to ER with seizures?
Sir, it can be due to any stroke, new like CVA. It can be due to any space-occupying lesion. It can be due to hyperglycemia, any metabolic disturbances like
so
hypernatremia.
broadly always you classify it into the etiological classification one will be genetic causes. Definitely in an elderly gentleman we are not going to think about it, and it's completely a different topic. Pediatric epilepsy with genetic causes, that is one thing. Second will be structural causes. Okay, structural causes will cover all these strokes, space occupying lesions, demyelination, viral encephalitis kind of syndromes, right? Third will be metabolic. So what are the metabolic parameters which can present with seizures?
So hyponatremia or
Hyponatremia predominantly, okay. Hypoglycemia, hyperglycemia, okay.
Then sir, hypocalcemia,
Very rarely hypocalcemia can present. Okay. Hypomagnesemia, a value of less than 0.8 is well known to cause agitation, seizure-like symptoms and all. Hyperthyroidism, again. Thyroid issues can cause. Uremia. So these all things will come into the bracket of metabolic parameters. Okay. So electrolytes plus thyroid plus uremic causes you need to definitely consider. Then what? Infection. So we genetic, we talked about structural, we spoke about metabolic causes, then infections. Yeah. Okay. Any infection to the involving the brain can present with seizure disorder kind of thing. Next thing will be immunological causes. Again, there is another kind of lot of immunological reasons which can precipitate as seizures. And never in an ER kind of situation, never miss out on both toxins and withdrawal symptoms. Okay. What are the common withdrawal symptoms which can present? Both alcohol and benzodiazepine withdrawals, opioid withdrawal. These kind of things can present with seizure kind of symptoms, and toxicological also. Toxicological again, various agents including drugs also you remember under that heading. Okay. What are the common drugs which can again? Commonest presentation will be fluoroquinolones. Most of the time we get patients who have been given fluoroquinolones following which they come with seizures. Carbapenems can rarely cause seizure kind of symptoms. Lot of chemotherapeutic agents has been attributed. TCAs, tricyclic antidepressants. Okay, again drugs which can cause epilepsy or seizure or seizure-like symptoms. Again, there's a huge list. So this will cover the etiological part of any patient who is coming to ER with a seizure. Okay, fine. So in this patient, we feel that it is a stroke. So what is the relation between stroke and seizures?
Sir, previous stroke patients can have scar epilepsy. Okay. Then sir, some patients present like with stroke, like the symptom is seizures. They are having seizures.
Again, usually stroke is not associated with seizures. Any of the times when you have seizure-like symptoms, always think about the etiology of stroke with autoimmune vasculitic kind of reasons is the one which can present as seizure with stroke kind of things. And second thing, as you told, is correct. In late onset kind of things, there can be a scar epilepsy kind of pattern where the brain tissue is scarred, and that can act as a foci for seizures. Okay, right. Okay, so you have a patient who have come in, already you feel that there has been 3 episodes, you know that the patient has defaulted his prescribed drug, that is levetiracetam. So once you receive the patient itself, you have that history. Probably you are considering to give the same drug, right? So there is already a loading kind of dose, or the patient is expected to have levetiracetam within him. So we need not go traditionally for a full loading kind of a dose, right? That is a rationale behind giving a non-loading or a suboptimal kind of a dose when the patient comes with a seizure, right? That is the logic behind it. So any patient who is coming with a new onset seizures, definitely we are going to give what is traditionally called as a loading dose of levetiracetam, which is a very high dose ideally. It is a 60 mg per kg is a recommended dose, and not exceeding 4 grams. Okay, that is a guideline recommendation for giving levetiracetam. Okay, but most of the time we end up giving 1 or 1.5 loading dose of levetiracetam. Okay, but always remember the recommendation is for 60 mg. Fine. So here also you are considering to give levetiracetam only, then that is fine. You have given a dose of levetiracetam, but the patient again goes into a witnessed episode of seizure. Here you clearly say that the patient had a seizure which was lasting only a few seconds, like 30 seconds.
Yes.
Otherwise also, like how do usually seizures present? Like most of the time it is self-limiting and it is within 2 minutes. So you have this traditional method of keeping metal and all inside the hand, no, for seizure. What's the rationale behind that? Because many people will vouch on that, right? Or the patient had seizures, we kept keys or metal, and then the seizures subsided, and they kind of have an association with stopping of seizures. Any science behind it? Any idea? So most of the time it is self-limiting. It's a wrongful association with the metal object. Even if you don't do anything also, 90% of the seizure will subside in 2 minutes. Okay. So that will come again within the definition, right? If you're going to be worried when the seizure persists more than 3 minutes. Right? Okay. Now you have this patient. Let us assume that the patient is having ongoing seizures within ER, and on arrival itself the patient is having seizures. And how will you approach that?
So first we'll keep the patient in the left lateral position.
Okay.
We'll hold the head down so that if he in case vomits, there will be no aspiration. We'll put him on oxygen. If we'll secure IV cannulas for drugs, and then
okay. Ideally, we go for 2 IV cannulas.
2 IV cannulas.
And if at all you get one, that is good enough. So what is the first drug you are going to give?
So Levipil. Lorazepam.
Yeah. Any patient who is having ongoing seizure, the drug of choice initially is benzodiazepine.
Yes.
It is most of the time it is IV lorazepam. What's the dose of IV lorazepam?
Sir, 2 milligram up to 0.1 milligram per kg.
Yeah, it is 0.1 mg per kg. Or there are other protocols usually to give 4 mg stat. Fixed dose protocol is 4 mg stat, or else you go with 0.1 mg per kg. Okay. So either of these doses you are going to give IV within 3 minutes of arrival to ER. That is our goal. Suppose you are not getting an IV line. So that can be another practical kind of a scenario. You have the patient, you have on the clock, you have crossed 3 minutes and the patient is continuing to have seizures. What should you do? We'll continue with your attempt to put an IV, but simultaneously you have to do something else.
IM or
intranasal. What are you going to give IM? Midazolam you can.
IM we can give.
You can either give midazolam IM or buccal thing, nasal spray or rectal. So all 4 preparations of midasolams are available. So 3 minutes of arrival, no IV cannula possible. IV or IO. In pediatric, definitely IO will be an equally good option. So no IV or IO access. Give either IM, buccal, nasal or rectal, whichever is available with you. Again, the doses will vary. What is the nasal dose? 1 puff is usually 5 mg. What we have here, right? 5 mg of midazolam is 1 puff. You give 1 puff of nasal spray. Okay, fine. So now let us assume that by that time you have put the cannula, you have given the first dose of lorazepam also, and simultaneously in a new onset seizure you are going to load the patient with one of the anti-seizure medication. Okay, what are the anti-seizure medications which are recommended as first line?
Phenytoin.
Okay. Most of the time phenytoin has been replaced with phosphentine now. What's the dose of phosphentine?
20 phenytoin equivalent per kg.
Usually 20 mg. 20 mg per kg is a loading dose which we give usually over 20 to 30 minutes. Okay. So if the patient is not on any anti-epileptics and it's a new onset seizures, phosphentine still remains a reasonably good option. Any alternative for phosphentine?
So phenytoin and levetiracetam.
Okay. But again, with most of the centers now, levetiracetam has become the first choice. Okay, and it can be kind of given in most of the new onset seizures, irrespective of the etiology. Okay, levetiracetam, as we told, the recommendation for the dose is 60 mg per IV. Okay, again that has to be given in 10 to 15 minutes. You can give the first dose of levetiracetam. Okay, anything else? Phenobarbital. The first line drug recommendation will be for phenobarbital. Okay, fine. So you give one of these 3 drugs, but even after that, let us assume that the patient is having another episode of seizure.
So we can give midaz now.
Okay, now you are going to, in all these scenarios, make sure that the airway is maintained. Okay.
Yes.
So if the patient is going to have continuous seizures, our major concern is going to be a compromised airway. At any point you feel during the course, like you need not wait for like 30 minutes or 40 minutes into the seizure. At around 15 minutes and all, always reassess the airway, and if you are feeling that the patient is continuing to be having active seizures, then definitely going ahead and securing the airway is of paramount importance. Okay, so we have given one of the three agents. If Levipil was given first as a second line, you can give fosmanide again.
Okay.
It has not improved. Okay, so now we have exhausted with two anti-seizure medications. Either of the three we told, the combination of any two we have tried. Okay, that has not worked. Now that is when you are going to consider about the midazolam.
Okay.
Okay, so again, refractory seizure. Now we will label it as refractory seizure, right? And you are going to start on one of the benzodiazepines, or what is the other agent?
Propofol.
Okay, fine.
So benzodiazepine dose would be 0.2 milligram per kg, and then infusion would be 0.05 to 2 milligram per kg per hour.
Not exceeding 3 mg per kg. That is the max dose of midazolam. Okay. So this is again, the key thing is to up titrate. You start with 0.2 mg per kg, and then you have to up titrate the dose to achieve seizure control. Okay. Again, in centers with continuous EEG monitoring, EEG monitoring is very much recommended.
Yes.
Okay. So you get the EEG on, and with the EEG monitoring, you kind of up titrate the midazolam dose to achieve seizure control. Okay. So if midazolam is not available or not working, then Propofol. Definitely next agent will be propofol.
1 milligram per kg IV.
Okay.
Then else ketamine can also be given 5 milligram per kg per hour.
Okay. So you try one of these anesthetic agents if it is not getting controlled with your initial anti-epileptic. Okay, but this is the time when we get in the specialist also. Epilepsy care has become kind of a subspecialty within neurology, and there is a lot of new drugs available, including oral agents, IV agents, topiramate, and all. Right. So one of those second line agents has to be tried in at this point. Okay. Again, remember that seizure is going to be a broad spectrum. It is not like a single kind of issue. Right. We have patients who have probably come in with a hypoglycemia, seizure kind of thing, which may not recur again. Right? A single episode, correct the sugar, patient is completely fine, no issues. You can have kind of refractory seizures. We have ended up giving 5 to 6 anti-epileptics along with midazolam for patients to attain seizure control. So it can be continuous seizures. What is non-convulsive status?
Sir, EEG will show that the patient is having seizure, but there will be no symptoms from outside.
So exactly. So that is again a cause of unresponsiveness in ICUs and things like that. Patient on ventilator, not waking up. Very strong possibility of non-convulsive status is going to be there. Okay. So there probably we'll need to again continuous EEG monitoring with midazolam infusion will be needed. Okay. Fine. How will you differentiate? What are the other differentials? Suppose you have a patient who is coming in with involuntary movements of limbs, and assume that, they are saying it is seizures. What are the differentials you are going to consider in here?
So stroke one can be hyperglycemia.
No, I'm not talking about the differentials for seizure. I'm talking about what are the other things which might, which we have to keep as a DD in a patient with suspected seizure.
Myoclonic jerks can be there.
No, the thing is that definitely the other DDs will be, as initially we discussed, syncope can definitely needs to be considered as a differential, right? Then migraine with aura kind of symptoms can present with query kind of seizure kind of thing. Again, TOTS and that is again a differential. Okay, so malingering, panic attack. These are the differentials which definitely you need to consider for a patient who has come with involuntary kind of movements. Okay, panic attacks. Okay, just parallelly saying, if syncope, as I told, is a differential, right? So the patient has complained of sudden unresponsiveness. Even with syncope, there can be a bit of posturing and aura kind of symptoms at all. Before the event, the person can have similar episodes. In those kind of situations, it became a little difficult for us to differentiate between syncope and seizure. Again, syncope, the etiology can be neurological or cardiac, right? Okay, fine. So always remember the various other differentials which can come in for a patient with suspected seizures. Okay, don't label it as seizure upfront. Okay, fine. You told about ABG. What is a kind of the surrogate thing which ABGs usually tell us? So lactate elevation. When there is significant muscle involvement and all, it's usually associated with lactic acidosis. Most of the time, it is lactic acidosis. It is not hyperlactemia. Okay, there will be pH variation also, and in due course, within few hours, it'll normalize. pH will normalize. Lactate usually lags a bit, but usually normalizes within few hours. Okay, so that again is kind of suggestive of a true seizure. Right. Okay, so we have discussed with the management. Workup. How will you work up a patient with onset seizures?
Onset seizures, sir will take an MRI, or then we'll also do an EEG monitoring for the patient. And so we'll rule out any reversible causes of seizure, like we'll find out the trigger, like all electrolyte abnormalities to be checked, and then.
Okay, fine. So definitely neuroimaging, depending upon what cause you are going to suspect. At certain situations, if you are suspecting a space occupying lesion or things like that, or raised ACP bleed and all, CT will do. If you are suspecting anything beyond that, demyelination, encephalitis, meningeal encephalitis kind of symptoms, definitely you will need an MRI with contrast kind of imaging. EEG, again, at a point, EEG may not reveal anything. You might need prolonged EEG, including video EEGs in patients who are having recurrent symptoms. So again, the treatment nowadays is not restricted with medications itself. It has extended to epilepsy surgeries, where we kind of localize the focal point in the brain with functional EEGs, and you pinpoint which is the exact focus of focus of seizures in the brain, and you kind of go ahead and either kind of ablate or remove that specific kind of area. So the scope of or the management of seizures has gone beyond like what it was like 10-15 years back to a complete kind of a specialized kind of management, where as I told initially, it's a kind of a spectrum where some things are very simple and something can be very complicated, requiring very expert kind of management. Okay, you want to add on anything? So by now, I think we at least it is beyond the scope of a class to discuss in detail the etiologies and everything. From an ER perspective, I think by now you know what all the key things to do. Like when a patient comes in ER, definitely at what point you are going to kind of consider intubating the patient. If it is remaining refractory after the initial drugs, what all the options available with us? Okay, if it is remaining beyond 30 minutes, what are the agents, continuous infusions we need to start? The imaging options which we need to consider, the role of EEG, okay, and the various etiological factors which we need to think about in ER. Okay.